Hi friends, I'm Dr. Anoop James George. I work as an emergency physician at Jubilee Mission Medical College and Research Center Thrissur. Today we'll discuss on the topic point of care lung ultrasound in emergency department. This is an important skill that should be acquired by anyone practicing within the confines of an ED because as you'll see, point of care ultrasound or bedside ultrasound is a simple tool that can help you to rapidly differentiate and diagnose most of the life-threatening emergencies that might turn up in your line of work. I'll be skipping the basics of ultrasound here because I believe that all of you will have had some kind of training and experience using your ultrasound machine and probes. If not, I suggest you do so because teaching ultrasound is entirely another session and beyond the scope of this presentation. Our discussion will primarily focus on the following key points. We'll discuss on the different lung signs and lung profiles, which will be the crux of our discussion today. We'll also discuss a few lung ultrasound protocols that are probably useful in your day-to-day care. And lastly, we'll have a quick review of some of the recent advances in lung ultrasound, some newer terminologies, science, etc. So let's begin. Point of care ultrasound has come a long way in our day-to-day patient care. We now use bedside ultrasound for different scenarios, as in obstetric emergencies, cardiac emergencies. We also use it for acute abdomen in trauma, vascular injuries, and probably whatnot. But for a long time, it was thought that lung ultrasound was not a practical investigation in the ED, basically because lungs contain air which are not amenable to ultrasound imaging and all you're going to get are artifacts. Much of the pioneering works in lung ultrasound was done by this great man, Dr. Daniel Lichtenstein. If you search the literature on lung ultrasound, you can see his name popping up in almost every major study. Now, he and his colleagues had identified that if you carefully interpret the lung artifacts, then they can give subtle clues to most of the underlying lung conditions. And for his contributions, Dr. Lichtenstein is popularly regarded as the father of lung ultrasound. Now let's discuss the 10 most important lung signs that you need to know when you're performing a bedside lung ultrasound in your ED. This is actually the vital key to interpret your findings that you come across on lung ultrasound imaging. On a normal lung surface, you can identify three important signs. These are your bat sign, the lung sliding, and the air lines. The signs associated with pleural effusion include the quad sign or the sinusoid sign. With lung consolidation, you have the fractal sign or the shred sign and tissue-like sign. The lung rockets or B+ lines are seen when the lungs or interstitial spaces are filled with fluid, as in pulmonary edema or ARDS, and these conditions are collectively termed as the interstitial syndrome. And lastly, you have pneumothorax, where the most important signs are the stratosphere sign and the lung point. Now let us look at each one of them in detail. Let's begin with the normal lung. Now before we begin, you must understand that both air as well as bone offer resistance to sound waves passing through them, and any sound waves that hit a bone or an air fluid interface gets reflected back to the transducer, and this makes them appear as hyperechoic areas on a lung ultrasound image. Now here we have an image that is taken with a phased array probe which is placed vertically on the chest perpendicular to the ribs. Now if you carefully see, you can identify two hyperechoic lines, one here and another one here. So these are actually the rib lines which correspond to the periosteum of the upper and the lower ribs. Now there is another hyperechoic line which is about 0.5 centimeters below and in between the two rib lines, and this is your pleural line where the lung sliding actually takes place. There is a hypoechoic area here and another hypoechoic area here extending all the way down, and this is actually the acoustic shadow that is cast by the ribs above because they don't allow sound waves to pass beneath it, so those areas appear hypoechoic. Now if I join the rib lines and the pleural lines using a line, then it looks or it takes this sort of shape which resembles a bat, and this is called the bat sign, which is one of the key signs that you find in a normal lung surface. And lastly, you have one more finding here, which is the A line. If you can see another hyperechoic line over here, that is the A line, which is actually a reverberation artifact caused by the rippling effects of the sound waves hitting the pleural line. So this is your normal lung ultrasound image where you have to identify the rib lines on either side, and in between you have the pleural line where the lung sliding occurs. You also have the acoustic shadow that is cast by the ribs. You look for the bat sign and the air lines. So here you can see the normal lung sliding. You can see the glistening pleural line here where a to and from motion occurs. That is actually your lung sliding. Now, a normal lung sliding may be absent in certain conditions like inflammatory occurrences, atelectasis, apnea, pneumonectomy, where a part of your lung is surgically removed, and of course, pneumothorax. What you should keep in mind is that an absent lung sliding does not always mean a pneumothorax. Of course, that should be your first diagnosis, but you should also be thinking about other possibilities that we've already mentioned. Now, sometimes instead of an absent lung sliding, you may find a diminished lung sliding in certain conditions like hypoventilation or a regional hypoventilation, as seen in some obstructive lung diseases and in cases of a contralateral bronchial intubation. Now, when you look at the image in an M mode or motion mode with the M line passing through the center of the pleural line, this is how you'll normally see the lung surface. Now, the top part here, up to the pleural line, appears more linear and organized. This is actually formed by the skin, subcutaneous tissue and muscles which are static during respiration. And the lower part here, below the pleural line, appears more grainy because of the alveoli which are dynamic and which moves in and out of the plane during respiration. Now the upper part resembles the calm waters of the ocean and the lower part looks more like a sandy beach. Hence this is often known as the beach sign or the seashore sign that you get in an M mode. Now coming to pleural effusion, let us first look at the figure on the left. At the top, you can see a hyperechoic line, which is the pleural line. It is actually the parietal pleura that you're seeing above. Now just below the pleural line, you can see another hyperechoic line here. This is the lung line formed by the visceral pleura, which is separated from the parietal pleura above by a hypoechoic area in between. This is filled with fluid in pleural effusion. This hypoechoic area is limited by the rib margins on either side, and if you draw up the boundaries as seen in the central picture, you get a quadrangular area in between the parietal pleura and the visceral pleura and the rib margins on either side. This is called your quad sign. Now if you place it in an M mode, as seen on the right side image, you can see a wavy pattern. This is because during inspiration, the visceral pleura moves closer to the parietal pleura, and during expiration, it moves away from the parietal pleura, thus forming a sinusoid pattern. This is also known as the sinusoid sign. Another finding that you can notice in this image are the B lines. You can see the B lines here, which we'll be discussing in the coming slides. In pneumonia or lung consolidation, the two important signs that you should look for are the tissue-like sign and the fractal sign. Now, here again, you can identify an area of pleural effusion here, as we have seen in the previous slides. You can identify the quad sign there. Now, immediately below the effusion, you can identify an area of lung which has the consistency of a solid organ like liver or spleen. This is actually the consolidated lung that you're seeing, and this sign is called the tissue-like sign. Now, just beneath the consolidated lung here, you can see an irregular border between the consolidated and the aerated lung, and this line is called the C line or the fractal sign. It's also known as the shred sign. So these are the important findings that you see in case of pneumonia or lung consolidation. And these signs have a high sensitivity for diagnosis of underlying pneumonia and can be picked up much earlier than before they appear on a chest X-ray. Next, we shall discuss the findings in interstitial syndrome as in a case of pulmonary edema. The characteristic findings on lung ultrasound include B lines and lung rockets. And these are formed by the movement of fluid-filled alveoli, which causes flickering lines to appear on the lung ultrasound. Up to 2 B lines per field is generally considered to be normal. When there are 3 or more B lines per field, it is always pathologic and is suggestive of an underlying interstitial problem. And now, when the entire field is filled with B lines, it is often referred to as lung rockets due to its resemblance to a rocket or a space shuttle during its launch. And this is often suggestive of a cardiogenic cause of pulmonary edema. And in the last figure, you can see certain lines, these are called the Z lines. The Z lines are just like B lines but are non-pathologic and do not have the characteristic features of the B lines. Z lines are common artifacts which are seen in more than 80% of the population, and they may be mistaken for coalescent B lines. Z lines are just vertical lines arising from the pleural line, but they are ill-defined. They do not erase A lines and are not perfectly synchronous with respiratory movements as are seen with B lines. The characteristic features of B lines are that they are hydroeric-comitial artifacts. They appear as hyperechoic lines in lung ultrasound, which are well defined, and they spread up indefinitely to the bottom of the screen. In the presence of B lines erases the A lines. You don't see A lines if there are B lines. They arise from the pleural line and moves with lung sliding when it is present. So these are the key findings that will help you to differentiate between the B line and the Z lines. Now here in this figure, you can see that the entire field has been filled with numerous B lines, and this is known as lung rockets, mainly because it resembles a rocket or a space shuttle during its launch, as you can see on the right side image. Now the presence of lung rockets is almost always diagnostic of a cardiogenic cause for pulmonary edema. So that's how you normally see the B lines. You can see that they are originating from the pleural line here and extending all the way down to the bottom of the screen, extending indefinitely. And you can also see that they are moving along with the pleural line during respiration. Coming over to pneumothorax, the two important signs are the stratosphere sign and the lung point, along with absent lung sliding. Now on the left side, we see the image of a normal lung as seen in M mode. We had already discussed this earlier. We had discussed about the seizure sign and all. Now on the right side, we have the pneumothorax image, which is again an M mode image. But here the normal seizure sign has disappeared, and instead you have linear lines all over, which is called the stratosphere sign or the barcode sign. This is due to the separation of the parietal pleura from the visceral pleura due to the trapping of air in between them. And this is a highly sensitive sign for pneumothorax. And remember that if you have this kind of a finding on your lung ultrasound, then you should always rule out pneumothorax as your first diagnosis. So that is the importance of the stratosphere sign or the barcode sign. Another important sign in pneumothorax is the lung point, which if present is pathognomic of pneumothorax. So let's see in this image, if you can see here at this point you can identify lung sliding, whereas lung sliding is absent over here, and this point at the junction at which the lung sliding meets the absent lung sliding is your lung point. Let's see that again. See, here you have lung sliding and here you don't have it, and this is the junction where the lung sliding meets the absent lung sliding. And the lung point is where the visceral pleura actually begins to separate from the parietal pleura at the margin of a pneumothorax, and identification of lung point is almost 100% specific for pneumothorax. And it also gives you an indication of the size of the pneumothorax by its location on the chest, that you can identify the probe. The distance from the sternum to the lung point approximately correlates with the volume of intrapleural air. So these are the two important signs in pneumothorax. You have seen them, both the stratosphere sign as well as the lung point. Now if you pass an M line along the lung point in M mode, you will get an alternating seizure sign and stratosphere sign as the lungs move with respiration. So if you see in this image here, you can identify the stratosphere sign, and on this part you have the seizure sign. So it is alternating between seizure here and stratosphere here. And if you see, you can identify that the M line here is passing through the lung point. And as already been discussed, if you can identify this specific finding, then it is almost 100% specific for a pneumothorax. So whenever you have a case of pneumothorax or suspected pneumothorax, always try to identify or look for a lung point. Now that we have seen the different lung signs, we are now going to build different profiles using a combination of these signs, which can help us to identify the common thoracic emergencies that we may encounter in our ED. Now let us look at these profiles. We have the A profile, which comprises of lung sliding and air lines. And if you remember our previous discussions, you know that this profile will be associated with the normal lung. But there are two other conditions which can have a similar profile. Those are the COPD and asthma. So if your patient has an A profile on lung ultrasound, then the differentials will be a normal lung, COPD, or asthma. Next is the A dash profile. Now here again you will have the normal A lines but with absent lung sliding, and this is characteristic of a pneumothorax. B profile comprises of B plus lines or lung rockets, and this is characteristic of interstitial syndrome. We have already discussed it. Now B dash profile again comprises of the B profile or the B plus lines, but the lung sliding will be absent. And this kind of a profile is suggestive of underlying consolidation or pneumonia. Now remember that absent lung sliding with B profile is not pneumothorax. For pneumothorax, the profile should be an A dash profile. You should have A lines. And as we have discussed, the presence of B lines will erase A lines, and then you can rule out a pneumothorax. Next, we have the AB profile. Now, this can be due to two conditions. Like, for example, let's say your left half of the chest shows an A profile and the right half shows B profile. Or let's say on the left side, the upper part shows an A profile and the lower part shows a B profile. In either case, this is called the AB profile, and this kind of lung profile is usually seen with pneumonia. On one side you have normal aerated lung, and on the other side you have a consolidated lung. And the profile that you're going to get is the AB profile. C profile, which comprises of C lines or straight lines, we have already discussed that, and this is classical of pneumonia. Next we have an A profile with PLAPS. Now PLAPS is one of the 3 blue points where you perform the lung ultrasound. These are areas on the chest. You have the upper blue point, the lower blue point, and the PLAPS point. And these are areas on the chest where you perform the lung ultrasound normally, where you place the probe. I'm not going to discuss more about the blue points here. You can read up all about that. What you just need to know is that the PLAPS corresponds to the posterolateral area of the lung, just above the diaphragm. Now, in this area, it could be possible that you could have a normal A profile on the upper and lower blue points, and when you screen the PLAPS area, you might find consolidation or tissue-like sign. You can see a pneumonic effusion, you can see the C lines, and all of these will correspond to pneumonia. So if you have a normal A profile and if you have these findings in the PLAPS area, then again it is suggestive of pneumonia. And lastly, we have the A profile with venous thrombosis. Now, venous thrombosis is not normally part of the lung ultrasound, but let's imagine that your patient has an A profile and is breathless, and you've ruled out COPD and asthma, and you also suspect pulmonary embolism for this patient. Now, in these cases, what you just need to do is to perform a screening ultrasound of the proximal femoral veins to look for any evidence of thrombosis in the femoral veins. And if the patient has an A profile with evidence of venous thrombosis in the deep veins, then it is highly sensitive of an underlying pulmonary embolism. So these are your different lung profiles which will help you to crack the mystery of lung ultrasound. Using these profiles, you can identify almost all of the major thoracic emergencies that we encounter in our AD. This is the summary of the Blue Protocol as suggested by Dr. Daniel Lichtenstein and his colleagues, where you make use of the different lung profiles to narrow down your differentials. Now let's see how we can make use of this Blue Protocol to arrive at the different diagnoses. The first thing that you should look for is the presence of lung sliding in the upper and lower blue points. If the lung sliding is present and is associated with the B profile, your diagnosis is pulmonary edema. The presence of lung sliding with A profile, what you do next is you do a sequential venous analysis. You look for any evidence of thrombosis in the deep veins, and if you find a deep vein thrombosis associated with A profile, then the most likely diagnosis is a pulmonary embolism. Now, if the veins are free, you move to the PLAPS point, and if the PLAPS point shows evidence of tissue-like sign or shred sign, then your diagnosis is pneumonia. If the PLAPS point is negative of any such signs, consider COPD or asthma as your diagnosis. Now, the presence of lung sliding with AV profile or C profile is again suggestive of pneumonia. Let's see what happens if lung sliding is abolished or is absent. Let's move to the other end of the algorithm here. The lung sliding is absent here, and you have a B dash profile. The diagnosis is pneumonia. We have discussed that. Now, an absent lung sliding with A dash profile, and you look for a lung point. If you see a lung point, a definite lung point means that it is almost always pathognomic of pneumothorax. Now, an A dash profile without lung point, the first diagnosis should be indeed a pneumothorax, but you must also consider some other possibilities like atelectasis, adhesions, etc. And you may sometimes need other diagnostic modalities to confirm your diagnosis. You can read all about Blue Protocol in the literature. I'm not taking up much time. But what I would like to say is that this is an important algorithm that you need to know when you're performing a bedside lung ultrasound. And a meticulous approach will almost always give you a diagnosis of the underlying lung condition. So the bottom line is, if your patient is blue, promptly perform a Blue Protocol. Several other protocols incorporating lung ultrasound has come up recently, and all of them have tried to simplify things in ED for the emergency physician. We have already discussed the Blue Protocol in the previous slide. The Rush Protocol, I believe, will be discussed in another session. Here we'll only be discussing the False Protocol and the Sesame protocols, which I feel are important in your day-to-day practice. You can read up the rest when you have time. Let's have a look at the False Protocol, which was again suggested by Dr. Lichtenstein et al. In 2016. It stands for Fluid Administration Limited by Lung Sonography. The peculiarity here in this protocol is that it is not a diagnostic tool, but it is useful in the management of unexplained shock, mainly using lung ultrasound. The False Protocol incorporates lung ultrasound as well as a bit of cardiac ultrasonography. In a patient with unexplained shock, a simple bedside echo is done initially to rule out any evidence of an obstructive shock resulting from a pulmonary embolism or a possible cardiac tamponade. Along with this, you also do a lung ultrasound to look for an A- profile, which is suggestive of a tension pneumothorax. Next, we move on to rule out a cardiogenic shock by looking for a B profile, which is indicative of pulmonary edema. If there are no P lines and the patient is still hypotensive with an A profile, then hypovolemic shock should be considered and fluid administration should be initiated, while at the same time looking out for the development of B profile. The appearance of B lines indicates that fluid administration has reached its maximum and now the lungs are starting to fill up due to fluid overload. And this means that you have to discontinue the use of IV fluids. A persisting shock indicates the possibility of a distributive shock, and you have to consider the use of vasopressors to raise the blood pressure. So basically, the False Protocol tells you what is the cause of shock and can also guide you with the therapy as well to know if your IV fluids are enough or if you need to start on vasopressors. So that is the use of False Protocol in the ED. Another application of lung ultrasound is for determining the mechanism or cause of cardiac arrest. For this, we use the Sesame protocol. This was again designed by Dr. Daniel Lichtenstein and his colleague Manu Malbrain. Now, it is a sequential approach to rule out some of the reversible causes of cardiac arrest. So let's see how Sesame protocol identifies the different causes of cardiac arrest. The Sesame protocol uses a systematic approach to identify an underlying cause of cardiac arrest. So the first step is to rule out a pneumothorax. So if in your lung ultrasound you find a B profile, then it indicates a cardiogenic cause of arrest and no change in management is required. You can continue with CPR. Now, instead, if you're getting an A- profile, then it is probably a tension pneumothorax, which is the cause of cardiac arrest, and you can relieve the tension by using a needle thoracostomy and later converting it into a tube thoracostomy. Now, if you're getting an A profile, then there are two possibilities here. One is hypovolemic shock, for which the management is with IV fluids and which is limited by the False Protocol. The second diagnosis is a pulmonary embolism, and for that you have to move to the limbs to rule out the evidence of a deep vein thrombosis. So that is your second step. You screen the proximal femoral veins at the V point and look for any evidence of thrombosis. The presence of an A profile with deep vein thrombosis is almost 99% specific for pulmonary embolism as cause of arrest, and this can be confirmed in step 5. If there is no evidence of DVT, you move to step 3. Now in step 3, you look for hypovolemia as a cause of cardiac arrest. You do a screening of the abdomen to look for any evidence of collection of free fluids. You can screen the Morrison's pouch, the renal angle or the pelvis. You can also screen the thorax for any evidence of massive hemothorax, which could also be a cause of cardiac arrest. Also, you can do a quick scan of the inferior vena cava to see if it is collapsible. All these are indicators of hypovolemic shock, and the management is administration of IV fluids. If none of these are present, you move to step 4. In step 4, you are ruling out cardiac tamponade and an obstructive shock as cause of cardiac arrest. You are looking for pericardial effusion here, and the best view is a subcostal view because it offers both a diagnostic and therapeutic window. If there is no evidence of tamponade, you go to step 5. So in step 5, you're ruling out a cardiac cause of arrest. So you're basically doing a bit of echocardiogram here. So in your screening echo, if you find no contraction, then it is asystole. If you're finding a dilated RV, then it probably indicates pulmonary embolism. Remember in step 2, we had said that you can confirm a pulmonary embolism here in step 5. So that is your indicator here, a dilated RARV or RV free wall hypokinesia with apical sparing or a McConnell sign. RV collapsibility is also an indicator of pulmonary embolism. On the contrary, LV collapsibility or a hypercontractibility of the LV is again suggestive of hypovolemia as a cause of cardiac arrest. So this is how you use the SESAME protocol, and it is helpful to identify some of the reversible causes here. Of course, electrolyte imbalance and hypoxia cannot be diagnosed here, and of course toxins also cannot be identified by this protocol, but some of the major reversible causes can be identified using a sequential approach with SESAME protocol. So what's new in lung ultrasound? In recent times, lung ultrasound has come a long way, and it now has a much wider application in the emergency department. So other than what we have already discussed, there are a few new signs which have come up lately, and we'll quickly go through some of these signs like the confluent B lines, compact B lines, lung pulse, etc. The first image shows confluent B lines which are seen when an entire intercostal space is filled with B lines, as seen in acute pulmonary edema or acute lung injury. The second figure shows alveolar interstitial syndrome. It is seen when two or more sequential intercostal spaces are filled with confluent B lines in any scanning area. The third figure shows compact B lines, which is the presence of concentrated B lines throughout the lung fields, which causes the acoustic shadows of the ribs to disappear within the entire scanning zone. So here you can see the compact B lines extending all the way down, and it is encroaching onto the rib margins, and the rib margins are almost disappearing. In the last figure, what you see is the white lung, when each scanning zone on both sides of the lung present as compact B lines. Here you can see that the rib margins are almost obliterated, and all you're seeing are thick, dense B lines. So the last two conditions are commonly seen in respiratory distress syndromes of the newborn. Another important lung ultrasound finding that you should know about is the lung pulse. Now let's say that you have intubated a patient and the endotracheal tube has gone into the right main stem bronchus. Now you have placed an ultrasound probe on the left side of the chest, and you will see that there is no lung sliding on the left side. Now how do you differentiate between a left-sided pneumothorax and a right main stem bronchus intubation? That is where lung pulse will help you. Lung pulse is the rhythmic movement of the pleura in synchrony with the cardiac rhythm. The lung pulse is a sign of complete atelectasis, which is observable even before any radiological changes develop. It can help you to identify a single lung intubation and thus differentiate it from a pneumothorax, as lung pulse will be absent in pneumothorax. The second figure shows dynamic air bronchogram. Here you can see hyperechoic areas in between the areas of consolidation of the lung. These are actually air-filled bronchi, and dynamic air bronchogram is actually the centrifugal inspiratory movement of air bronchograms more than 1 millimeter within the consolidation. It helps to differentiate a pneumonia from resorptive atelectasis, which has a static air bronchogram. The third figure shows the double lung point sign. So here it is. So the double lung point sign actually refers to a sharp boundary, as you can see here, between the relatively aerated superior lung fields and the coalescent B lines, which represents the interstitial edema in the basal lung fields. It has a reported sensitivity of around 76% and a specificity of almost 100% for diagnosing transient tachypnea of the newborn. In the last slide, you have the power sliding. It refers to the use of power Doppler to help identify lung sliding. Power Doppler is a very sensitive tool and it helps to pick up even subtle flow and movement in the pleural line. If there is lung sliding present, the power Doppler will light up the sliding pleura with color flow, and this technique can be especially useful in cases of subtle lung sliding when direct visualization may be difficult or you are doubtful that there is any movement in the pleural line. So these are some of the lung signs that you can learn about. There are also many other lung signs. I'm not going to discuss all of them here, but you can always read them up in the literature. The application of lung ultrasound is not limited to the conditions that we have just discussed. These are some of the other lung pathologies that can be identified on a lung ultrasound, like bronchiolitis, cystic fibrosis, bronchiectasis, etc. Well, I'm not going to discuss them here right now because these are not usually managed in the ED except maybe for bronchiolitis. But just know that lung ultrasound is becoming more useful these days to identify most of the lung conditions. There are also some newer lung ultrasound protocols that have come up recently, like the Extended Blue protocol, the Trace protocol, FUSA, FASH protocol, etc. So all these can be helpful for an emergency physician in ED, and all these will take you through a systematic approach to diagnose different conditions. So it is good that you know about these protocols. You can read them up in literature. The cutting-edge application of lung ultrasound is in neonatal emergencies like the transient tachypnea of newborn, pneumonia, meconium aspiration syndrome, pulmonary hemorrhage of newborn, and several similar conditions. Now, normally these would warrant frequent X-rays for diagnosis as well as for assessing prognosis, but using lung ultrasound, it is much more easier and without the risk for increased radiation. These are again a list of current applications for lung ultrasound. Now, if any of you are planning to do a research or thesis in lung ultrasound, these are a few areas that you can consider working on. There is an immense potential here that can be tapped. So, if lung ultrasound is your thing, then I think these are some areas that you can consider working on your research project. So finally, the take-home message is that you should keep practicing your lung ultrasound for confirming your clinical diagnosis. Always, when a patient comes in a respiratory distress, grab your ultrasound machine and perform a lung ultrasound. Have a systematic approach and watch out for your different lung signs and profiles. Beware of pitfalls. Remember that an absent lung sliding is not always a pneumothorax. You have to have other diagnoses also in your mind while you're performing a lung ultrasound. You can improve your skill only with practice. So practice makes you perfect. And finally, like I said, there is an immense potential for research here in the field of lung ultrasound. So if you have a taste for lung ultrasound, consider taking it up for research. So that's all, friends. I hope I have shed some light on lung ultrasound in ED. This was not an exhaustive presentation, and you can always go back to fill in the gaps. So thank you all for your patient listening and have a nice day.